assistant professor university, and I will be at University of California in San Francisco next month, inshallah. My main niche is basically minority health, health equity, and women's health is what I do on a daily basis. And I do believe that we have talked about women's health before, but just to give you guys a heads up, women's health is every health issue related provided to women. So diabetes in women, hypertension in women, everything that is related to wellness and welfare of women that you treat in men, simply because I do believe that they are different, and doesn't necessarily mean that one is better than the other. They're just different, period. No need to kind of differentiate between both based on who's better or who's less. So today we'll be talking about contraception as a concept. As you can see, contraception has grown wonderfully, and it's very interesting in our culture. يعني في الثقافات العامة بشكل عام, all cultures, by the way, have perceived contraception as part of the conspiracy theory. So I want to bring up some historical background real quick. Let me know if you guys have any problems hearing my voice, understanding my accent, or seeing my slides. I'll take silence as we're good.
It's all fine, thank you, Lee.
Okay, so we're gonna pretty much shed the light on contraception counseling and what things we actually need to have in mind when you are counseling a couple or a woman. Most of the time, this is what happens. She has to bear the responsibility or accountability to prevent pregnancy from happening. So one thing you guys can do as clinicians is understand that contraception is a societal concept. The whole community contributes to improvement of utilization of contraception. When you do the counseling, ask yourself, what's the indication? This makes a huge difference in how you code your service. يعني انت لما بيجيك حد على العيادة and you are actually talking to these couples in the clinic, you're thinking, what am I coding this service for? And I'm gonna shed the light on some of the I would say historical societal barriers to contraception as an indication for prescription, how you can actually serve your patient better when you learn the indications in the back of your mind. Also methods of contraception, what kind of ways or approaches you are prescribing to your patient in order to prevent pregnancy from happening. Contraindications, why you would not prescribe contraception, period, right? Not just hormonal contraception, okay? This is very important. And then when you're trying to switch from a contraceptive to the other, because as I've introduced, this is a societal concept and phases of our life differ, hence the contraceptive modality that we use should actually be changing. We should expect that for patients. And sometimes if they don't bring it up, you bring it up in your counseling as well. And then we're gonna shed the lights on some case discussions. I'm gonna try not to bore you as much as I can. Let me tell you, birth control, the first mentioned was BC, 1850 BC. Does anybody know what was the oldest birth control that was ever used?
I think coital like stopping coitus.
Coitus interruptus.
Pull out method.
Yeah, actually there is something before that. In the ancient pharaohs' times, in the Egyptian times, they used medications. These medications were made from plants specifically growing in the North African sphere, and others were growing in the Australian side, but that was not necessarily known. They found it later on in Australian continent, but in the North African hemisphere, mainly like what is called now Libya, the ancient Egyptians actually made their own, what could be now very toxic contraceptive from a plant called acacia. And it has multiple subtypes of it. And I'll show you guys what it looks like. It looks like a sarkhasiyat, as you can see. It looks like these little leaves. They would actually smash those, mix them with honey and lint, which is a byproduct of cotton. They would put all that together and they would stuff it either through the vaginal vault or use it with tar on top of the penile part. So birth control is an ancient concept. It's not a modern concept. It has nothing to do with conspiracy theory, it is very much knowing that pregnancy is a huge event that a woman's body goes through, and the loss of lives due to pregnancy, especially those who were back to back, did not necessarily have any planning options, were plenty, right? So in Libya in general, these plants were used, and there are papers, like old ancient yellow papers, that they had the recipes for those. Avicenna, for instance, had used these. There's a huge chapter in his book, The Law in Medicine, Al-Qanun fi Tib, a huge chapter speaking of all of these inherited birth control remedies and medications that were prepared. That was before coitus interruptus. The reason being said is that anciently, by the way, the process of how fertilization of an egg was not fully known, and there wasn't truly a full trust in a woman's body not capturing the sperm during the fertilization process. So medications were first before coitus interruptus. Coitus interruptus followed like in the 850 afterwards. So for you guys, you have to understand that when contraception was not successful, people had to abort children. So when I hear the discussion as a clinician about contraception being part of conspiracy theory, or this should not really be part of our culture, it really makes me sad that we don't necessarily learn from the history. Pregnancy is a huge physiological event, and it can negatively impact the lives of families when you lose a mom. Because at some point in the 1800s, believe it or not, early 1800s, in the United States, the immigrants' average births of a woman was 8. So an American woman in the United States, before it becomes the United States, like in the North American sphere, a woman would have 8 children on average. There's more, there's some less. So those who made it to life, that was the average. And towards the end of 1800, because of these medications and preparations and abortifacients, basically aborting children in order for a mom to live, they ended up with 3 to 5 as an average per woman. That's why contraception matters, because it actually saves lives. It doesn't necessarily cause infertility or it negates fertility. It just gives the family or the society a chance to regulate and plan for multiple reasons. And I'll show you guys in a second the real factor that we use it for that. And the links will be included in the handout so you guys can entertain yourself with reading. I'm very fascinated with the history because I just feel like we can't necessarily we can't reinvent the wheel. I can't believe that us now in the 1900s or the 20th century, 21st century, we're the only one who thought that we need a break from having a child back to back. They used also breastfeeding consistently. They breastfed for almost 3 years exclusively, meaning children were not even fed anything but breast milk in order to maintain a contraceptive period of time. Indications, as I said, maternal mortality is huge. This is from 2015. Unfortunately, it's getting worse even in developed countries. The reason for maternal mortality now is much more than just medical errors. According to the CDC, 2 of 3 deaths of pregnancy-related deaths are preventable. So 66% of the cases that die due to pregnancy complications are preventable. It can be pretty much conception counseling prior to getting pregnant, or even family planning, so it's not back to back, or making sure that the cardiovascular condition of a woman is healthy. And of course, now we are recognizing the racism impact of it, the access to health care. Physician competency is, I think, coming next. We're not necessarily as competent as before because we are advancing in technoscience, but we're not necessarily going to the basics and foundations. That's why I want you guys, if I was to teach you anything today, always remember your basic science, always foundations, because contraception is basically physiology of a woman, physiology of conception, and the geniusness of pharmacology, okay? Indications mainly to prevent pregnancy. Secondary indication is family planning, and to some extent, very minute extent, is protection. Once you have sex, unless like you're really protecting the whole vulvar area and the whole genital area of man, STI prevention is not like something you can really get from most contraceptive modalities, but these are secondary indications you can actually put to code in a visit. So I want you to think as a clinician, the benefit from doing this piece that is basic is understanding how to navigate a patient encounter. Any comments or questions so far? Okay. So this is the decision making. It's a reproductive decision. When I come to you as a couple, me and my spouse, and what we are thinking that we want to delay pregnancy or we don't want any kids, the factor wheel that I have in my mind and you are partnering with me on is what my culture, my society, my religion says, how educated I am, right? That is why, honestly, like contraception, I'll come to the ages that like the stages of contraception. How much do I know about my body, right? Can you trust me doing fertility based awareness methods? I like the new name for that. Actually, luckily we're changing concepts in order to match how much we know about our bodies. What would my friends, my family expect from me? How stable is my marital relationship? Career is a huge thing for females nowadays. That is why we have delayed reproduction, or what they call geriatric maternal age. I hate that term, but eventually we will be able to change it, but it's reality, right? Like you had to do that arbitrary break age, اللي هو 35 سنة, 35 years of age. Law and policy. For all of you guys who are practicing wherever you are, if you're practicing in Egypt, in North Africa, if you're practicing in South Asia, if you're practicing in the North American sphere, in Australia, women are not left alone, okay? The policy are telling women what to wear, what to take, what clinic they can go to, the insurance. I think we need to mute someone. Thanks. So I think that if you guys think about the factor wheel, you have to be, as a clinician, once you graduate medical school and even during residency, I strongly encourage you guys to do like 20 minutes reading once a week, twice a week, about what the policies and laws are saying. I've always wanted to avoid politics, but politics are not letting go of women. So you have to understand how the bill impacts your day-to-day interaction. And honestly, like since, for instance, I practice in the United States, since Obamacare came in, the Affordable Care Act, and there has been some improvement in the Planned Parenthood project, I have some leeway in prescribing medications for contraception. But I do remember that I practiced in an area, rural area, where contraception was not allowed in the Catholic-based hospital that I was in. So I had to use different indications, and I had to be authentic and honest to myself and find different indications. If I can't, then I would have to refer them to an outside institution that does not have that kind of, cultural sphere. Services availabilities, methods, are they covered by insurance? Are they within the physiology of your patient? So for instance, look, when you do pelvic examination for these patients, from the first pelvic exam of a whole woman examination, I'm thinking in my mind, this patient is a good candidate for an intrauterine device or not. She's okay for an IUD or not. Okay, so when you are dealing with women, you're looking at them, for instance, BMI, looking at the weight, looking at the height, looking at the fat content. You know your patient very well. You can deliver information pretty much accurate to her factor wheel. So bear that in mind if you don't mind. Any questions so far? Okay. Another thing that I don't know if anybody talks to you about it, the contraception starts from birth. The moment that the fetus has a womb, their life course is pretty much towards them getting married and having kids, right? So, and health education is not necessarily on our side in most continents, by the way. I think there is a worldwide problem in delivering health education, specifically reproductive health. So from birth to puberty, the contraceptive stages is by teaching these women, women and men, how does their body work? How does their physiology manifest itself? And how can that contribute to conception, right? I do remember, like, for instance, I had a couple of, so I had I had families actually tell me that they use different words for body parts. I don't necessarily recommend that. So when you do reproductive health education, make sure that boys and girls know the respectful and appropriate names of their body parts. Start simply there. That's where contraception or conception education starts. Puberty to marriage. Let's say, for instance, or puberty to a significant relationship, right? You have pills, you have injectables. Condoms are preferred in this situation, especially if relationships are not stable. And this is becoming really a worldwide problem, that people do engage in sexual interaction, or at least premarital or pre-significant relationship interaction. We can promote, morality and ethics, but at the same time, you have to have a plan B. So I want you guys to think like clinicians who truly care about relationships or accountable decisions, or patients who do not necessarily have even the options. Sometimes you grow in an environment where normative do not necessarily speak to healthier options or righteous options. So you have to take that into account and be prepared. Marriage to first child. This is really huge. Any method would work, but a lot of times the myth would be, if I take contraceptives, it can cause infertility. That is why I wanted to tell you from the beginning, contraception is just a way to prevent pregnancy from happening. It shouldn't impact your fertility. The physiology, like the basic science of it, does not impact your fertility. I'll talk about like how it can, let's say, reveal infertility issues later on. We'll come to that when we do myth busting. During breastfeeding, a lot of times breastfeeding is actually pretty much reliable and it's very healthy for a woman's body. But for a while, we kind of condescended women who are breastfeeding. Now we are seeing another pendulum because, women health always goes through pendulums because we don't speak for ourselves. There are a lot of people speaking on behalf of women in the healthcare sciences, but during breastfeeding, you want to use something that does not impact the prolactin level. So that's the type of discussion you want to have with your patient. Also, how long? Do you want that long-acting reversible contraceptive? Do you want another child? After breastfeeding, you want to look at, like you want to shift to something that would reset back to your physiology. Because a huge part, I don't know about those who practice in Middle Eastern cultures, but my Middle Eastern patients, MENA in general, like the Arab patients, or people who come from South Asia, they really like their set periods. And as we know this, for instance, for those who come from an Islamic background, if my period is not regular, my rituals and my intimate relationship with Allah subhanahu wa ta'ala, or like with my God, to pray, to fast, to go to Hajj or to do Umrah, these are all impacted. So you have that religious factor from the real factor into your mind. Tamam? You look at if a family is complete, that is a decision that couples do. I know that there's a lot of religion and culture into that. Your job is to run always informative model. Does anybody remember when I talked about the models of interactions with patients? Do you guys remember the 3 models of managing a patient encounter? Anybody? So when I am dealing with a patient mental model, which is dying, it's good to use that with adolescents, maybe with kids to an extent. But with adults, with people who have intellectual capability of understanding you, they can understand your language, then I prefer the 2 other models, which is informative and deliberative. Informative, I'm just sharing information. This is all what we know about your case. This is all what we know about your options. And which one would you like to, decide upon? Deliberative model is that the benefits of certain options will outweigh the risks given the current evidence. Another thing I want you guys to know, that women's health has a huge gap. There's a lot of gaps. Women's health, there is a lot that we don't know. We just started actually providing women with hormonal therapy after the WHI, which is the Women's Health Initiative study. Women were deprived from so many kinds of treatments, and the pharma was stopped for ethical reasons and because the risks were outweighing the benefits, and the research in women's health paused. What we are learning about women's health is really expanding, alhamdulillah. So what I want you guys to think about is, mostly with this situation, I am sharing information and I'm not impacting the decision either way. for as long as your patient is intellectually capable of making decisions. They're not minors and they're not intellectually challenged. تمام؟ يبقى مريضة مش متخلفة عقليا, she's not adolescent, she's not struggling with يعني مثلا understanding your dialect or your accent. You really should share all the information with justice, يعني sharing all kinds of information. Be aware of your biases. تمام? You don't think on behalf of people. They know their situation. Let them speak to you, and based upon which you decide on contraception. That's the art of medicine. تمام? So I think that's like the previous slide is something that you guys can use. So methods of contraception. Types of them, اللي هي rhythmic, and I look at my cycle, my menstrual cycle, if it's regular, if I know like body basal temperature, if I know the idea of ovulation dates, if I know the cervical mucus, all of these, we call it fertility awareness methods. And the variable factor in a heterosexual relationship between a man and a woman basically is the woman's physiology, right? The change and the preparation of a womb is in a woman's body. You have the rhythmic ones, which is basically fertility awareness. I'm aware of how my body behaves to have a baby, to prepare for a baby. And then there are the barriers one. You just basically, because you understand the physiology of conception, you just don't want the egg and the sperm to meet. So anything barrier-wise, and by the way, barriers were older than the rhythmic ones, as I told you before. They used the lint, they used cervical caps. They made cervical caps from lamb skin and they put it into a woman. They put tar once, interestingly, in the history. And then the hormonal ones, those are only applicable to females. So I want you also to think about something, guys, especially who are going to do any kind of women's health. Contraception is the job of both parties, both spouses in a relationship. So all of these methods apply to males except for hormonal. We're not going to give hormones to a male partner. Rhythms, barriers, surgical, all of these can apply to a male and a female. Hormonal is only females. Okay. You also think, do you want an irreversible methods? Of course, now, luckily, as I said, technoscience is advancing. And technology is the biggest thing that is advancing in medicine, unfortunately. على فكرة, يعني this is a problem because we're not really catching up with the art of medicine. We have a lot of technology that we use to diagnose and do instead of preventing, right? So the irreversible ones can extra hurdle, like the tubal ligation or the vasectomy or the Eshore. All of these can to be an extent be reversible, but it's not necessarily recommended. So if you want to do it, there's a contract between a physician and a patient. Reversible ones can be short-term, and a short-term is considered the breastfeeding period. Some scientists say they are either like 1 year or 2 years. But in general, we consider a short term. For instance, if I was to counsel for IUD, if you want a contraception, it has to be less than a year to be considered short term. Anything more than a year, you can definitely discuss LARC, which is long-acting irreversible contraceptive. Ideally, you want it to be highly effective. So you want it to do what it's supposed to do, which is prevent pregnancy. You want to have no side effects to minimal side effects. You want it to be affordable. It's the less operation dependent, meaning I don't need to see a physician. I don't have a problem with access. So operator independent, that would be an ideal one. Culturally accepted. So your culture in the factor wheel accepts that. It's available and there's no healthcare personnel needed, meaning the cost on the system is much less. So I want you to think about contraception from that concept. Rhythmic or behavioral. Behavioral, like the top thing that can prevent contraception is not to have sex at all, which is abstinence. That's 100%. This happens in many cultures, especially religiously oriented ones. Predicting fertility. I want you guys to remember this. Fertility awareness methods were second to history, and now they are not really relied upon for contraception. Quite the contrary. We want women to be fertility aware. Nowadays, we use these mostly for conception, yani for infertility treatments. We don't use basal body temperature and calendar ones for contraception anymore. That is why the research for the studies are not expanded on that. Very few people do want the natural approach because everything in the culture here in the North American sphere is about convenience, magic pill or get it done. And also like the periods are not always regular, especially with the stress and the cultural pace that we run. Very few that you see women have like pretty much a calendar accurate period or menstruation. So in the back of your mind, you guys as clinicians, your understanding of the fertility awareness methods is really to help women conceive rather than prevent pregnancy. That's how you think about them now in the current clinical sphere. Coitus interruptus is actually amazing. It's operator dependent, so it depends on the male much more than the female. So it's not really female empowering according to the current or modern. This is a modern concept. It's not female empowering, so the woman doesn't really have much of a say in the coitus interruptus if the male doesn't know how to operate it. I don't know about people who practice outside the US. Do you guys have a different experience? حد عنده تجارب تانية regarding the predicting fertility? Most of the research, by the way, is India, Europe, and the US. The few countries that I've seen studied for predicting fertility that are like in the Arabic speaking countries are Iran and Lebanon. And it is inconsistent and insufficient evidence to find like the right percentage that would make that work. But if you do a proper education, health education, these are very reliable to prevent pregnancy in a woman with regular periods. Anybody has a different experience that is not documented in research?
I think it's hard to find a different experience than this in the MENA region, because mostly medicine here is like more paternalistic. So, and patients don't really have the option. So it's always like, it's not an option to be told to patients. Patients don't get this option. They either do not go to a clinician at all, then we don't know about them, we don't do research, or they go to a clinician and the clinician says, just do 1, 2, 3, like take this IUD.
Correct. So it's up to you. I think I would respect the culture. If I was to practice there, I can do my job in my local region. So I really like in my life, professional or personal, is to think globally but act locally, right? So if I look at that patient, one patient at a time, those who come to me, I just want them to know, because it's an aman, right? I'm accountable. I am entrusted with their health. So I let them know what options they have. But if you're the patient cohort that you have, Kareem, in general, and I do know that from the couple of years that I practiced in Jordan, they actually do want you to tell them what to do in some extent, especially when the wheel factor is so overwhelming. They have so much on their plate. They want to trust you with a decision on their behalf. That is where your medical knowledge comes in. And you, as a clinician, knowing the wheel factor, you put all of that in your mind and you think, if I was in their shoes, what would be the safest clinical option? Which is a dangerous position to put ourselves in, to decide on someone's behalf. But if this is the culture where paternal model is, you guys have to be aware of the wheel factor, right? How am I serving this patient, right? You shouldn't, for instance, recommend an IUD in a version 18 years old female because she's afraid to get pregnant, for instance, right? That right? You wouldn't recommend something like this in a culture where this is honored or respected. So I totally agree with you. I think that we're missing the portion of those who do not really knock at doctor's office. They don't really knock at doctor's door. We don't necessarily know if those people are successful. I know so many, like from social networks, that they use fertility or predicting fertility, but they had been taught how their physiology works. For you as clinicians, it's very important to understand just a little bit of what the basal body temperature is. The basal body temperature is our temperature at rest situation. Yeah.
But for me as a clinician, I actually I don't think I can trust this method for predicting fertility, because it's quite unreliable. It could be quite unreliable, right?
So this is not really supported by evidence. This is not supported by evidence. That's what I'm saying, is that we are biased, right? Because in the back of my mind, these patients are not educated enough or reliable enough. But for a woman with a regular period and very in tune with her body, they can really tell you, like I had few of these patients. I'm very fortunate that I see all kinds of patients in the spectrum. I really have a bunch of patients who just use fertility awareness method. They know exactly, they can tell you even when their egg is being released. Their period is regular, but their life is regular too. They do exercises 3 times a week. They have healthy BMI. They don't smoke. They don't drink. They've never taken hormones before. They have the conspiracy theory, and they use these ovulation kits over the counter, and they have been doing it for years.
Yeah. So this is the California mom patient, right?
Well, I'm not in California yet, but I wouldn't be surprised that I would see more of that, right? The thing is, in this situation, that's what I'm trying to say, is that it's in our hands to believe that since we don't have an evidence, your bias would be working through. I would tell the patient, this is what you need to know. Is your period regular? No. If she said yes, do you feel changes around the ovulation? Do you feel any changes during the cycle? Can you tell me how do you, can you chart your cycle? So this is, for instance, I don't know if you can see, this is the chart for the body shift, the biphasic shift where the temperature changes. And these are the days, the 1 to 6 prior to ovulation, where women need to avoid having sexual intercourse, full sexual intercourse unprotected, right? So if I explain to this patient how her body works and I give her this chart and she fills those, she's very reliable to do that. The question that I have for this patient is why you are concerned about hormones. Sometimes their fears is like, I heard they do cause cancer and my maternal aunt has cancer. So I talked to her about non-hormonal options. Condoms, they're not comfortable, they cause allergy. She thinks of condoms as being chemicals as well, right? I don't know what they make condoms from. I'm allergic to so-and-so, but she just doesn't have faith in the current modern healthcare system. That is why I go sometimes into history and I share these articles with my patients. Contraception is an ancient model. Before colonization, even, well, technically the pharaohs were colonizing and oppressors, but before the modern culture, it's an ancient concept, and medications and barriers were used before, right? So if that is what my patients want, I will empower her by education. So I encourage you guys just to have, at least in the back of your mind, these rustic papers about how the body basal temperature works, which is your basal temperature at baseline or at rest. And then how does the ovulation, and think about that, أنا عايزاكم تفكروا بالموضوع ده شوية, تمام? Releasing an egg is an inflammatory process. Okay, you have to break a tissue, cause like a break in that tissue, kind of necrosis, a mild healthy necrosis, to break the corpus luteum and allow the egg to get out. This is an inflammatory process, because of which, and it is a process. على فكرة, for those who believe in the Quran, or believe like in the, you know, like in the Genesis or the Khalq, it's very interesting that Allah خلق الكون في 6 أيام. The whole creation is in 6 days, and preparing for this egg that has the secret of the universe is in 6 days. I don't like really to make these like connections in the back of my mind. I really don't necessarily feel like I need any proof, but it was amazing to learn that when I learned the physiology of a woman's menstrual cycle. It's amazing. It's miraculous. It's miraculous. It takes 6 days to break that corpus luteum and release the egg, and in that 6 days, that process until like you have ripened the corpus luteum where it's broken out, that's where the egg comes out, and that's the release of the temperature. It's higher for a few days. So in the process of preparing to the egg, which the sperm can survive up to 72 hours, we recommend these 6 days when the preparation of releasing the egg is happening. Take a break or use a barrier, a condom or something. You either do abstinence or coitus interruptus, whatever, but don't allow that sperm to occupy your vaginal hole during that time. So that inflammatory process gives you some of that temperature and increases the basal body temperature to that that you can actually, and it's 0.5 to 1 degree above your basal body temperature. And that's how the release of the eggs happen. You guys know that this is probably one sign that couples who have infertility would be waiting for every month desperately. I worked with the IVF for 1.5 years with Dr. Leslie Apia. She's one renowned in the United States. Now I think she's practicing in Colorado. I worked with her when I was in the University of Kentucky. Seeing the look on people when they come and they have had that increase in temperature, it's amazing. It's amazing what we take for granted on a daily basis, that we have like that increase in biphasic shift. And unfortunately, it doesn't happen in all women. So even you can release an egg, but it doesn't necessarily, that body temperature biphasic shift, it doesn't all happen in some women. And studies are being done in the IVF or infertility work to check if those women are less likely to be fertile than those with biphasic shift, and the evidence is insufficient. Basic science, basic science, basic science. That's all what I want you guys to understand. The physiology of a menstrual cycle and the ovulation is just an endless treasure box. We just didn't dedicate enough research for women's health. Okay, so just learn these now and then accumulate your knowledge over time. Barriers, they can be condoms for males or females, and these are the only ones that provide protections against STIs. Any other barriers, like in this case, for instance, the picture that you guys see is basically like a woman's female condom. As you can see, that's the only way you can provide protection. It has to really cover the whole vault. Otherwise, herpes can be transmitted. HPV, all of these viruses can be pretty much transmitted. Syphilis. Cervical caps, sponges, diaphragms, or spermicides, these are all barriers from allowing the sperm to fertilize the egg, and they are not protective against STIs. Female barriers, there's the diaphragm, there's the cervical caps, and I put some links because I know that some of you guys do not get exposed to it. And in my mind, by the way, in medical school or medical education or graduate medical education, I like to share with you guys the things that you may not see often. So you would have just, like a small file or folder in the back of your mind. When you get exposed to it, oh, I saw something like that. We like to share the rarities and scarcities because you may not get to be exposed to it in practice, but if you were to, then you have something to start with. And the links for these, the She Cares is one of my favorite websites. You can pretty much explore that at your own. Condoms, of course, because everything for a male, and I'm sorry for my bias here, males get the fun stuff, right? All kinds of penile condoms are basically to improve friction or improve sexual pleasure, even though like their curve or climax for orgasms is much easier for women, yet this caters for both partners, but it does all the ultra thin and anatomical physiologic interaction during sexual intercourse. Unfortunately, none of these male condoms are biodegradable, which is something I'd like to see. Meaning, you cannot throw them outside litter them because they don't degrade. It takes them centuries. So you have to really discard it pretty much as a biohazard, unless you want people to pick up, sperms and semen from others. Something, by the way, that doctors do not teach males. If we don't do health education or sexual education until puberty, I don't expect males or females to know that. I'm really surprised by how many of the couples did not necessarily know how to discard biohazards or condoms use. Hormonal, think about it as steroidal or chemical, right? Chemical in this case is only the copper IUD. Everything is hormonal, and every hormonal manufactured contraceptive is from steroids. This is important for you guys to understand because any problems with fat content or changes in the fat content can really impact the lipophilic steroids. Lipophilic, yani they love the fat. They kind of the fat content of the body does play a role in how much of that hormone is available for a therapeutic effect. عشان يشتغل أنا عايز أعرف قد إيه في نسبة ناس adipose tissue أو fat في ال women or females اللي are taking it. Think about the methods or prescriptions as vehicles to deliver that hormone. يعني أنت you're not prescribing a pill or a patch, you're prescribing a hormone in a pill or a patch to be delivered through those. So these are vehicles. The pill is intral, meaning it gets impacted by gastrohepatic or enterohepatic bypass, right? Enterohepatic metabolism. So if the liver is not healthy, whatever you take through the mouth is going to be negatively impacted. If the stomach is not healthy, it's going to impact whatever you take orally, right? The patch, the depot shot, and the implant are para-intral, systemic. They impact the whole body. They go through bloodstream to the receptors. That is why the dosage in those did not need to be high from the beginning. And hence, the changes now in these systemic ones are towards lower doses since they bypass the liver. The IUD is pelvic. So the pelvis of that woman would determine if the type of the IUD that I'm using is appropriate or not. And I can throw some information in that. So for instance, the pills, they are all small. They are different combinations. They are either mini pills or combined, meaning have estrogen and progesterone. And they can be 21 days, 24 days, or 28 days, meaning you're delivering hormones throughout all the cycle. The patches, they all have estrogen and progesterone because it's systematic in order for that to give you like something similar to the cycle. The depot shot and the implant are only progesterone. And the IUD can be either copper IUD, which is not plain. The plain IUDs died. The first IUD actually that was done in 1920, that was a plain IUD, just a mechanical barrier to cause an inflammatory response inside the uterus and prevent implantation. That died because it killed a lot of women with endometritis. Now we have the copper IUDs and different IUDs, and these IUDs actually are different sizes. The largest of those is the copper IUD. The Lolita is smaller, and the Marina is in between. The Lolita has like lower dose of levonorgestrel, which is a progesterone, and the Marina has a higher dose and lasts for longer. The things that you need to know about the IUD, if you are prescribing an IUD delivering hormones, you have to check that the pelvis of that woman is less than 10 centimeters or more. So if you're just prescribing it for a woman who has not had babies before and she just doesn't want to have babies for whatever reason, you have to choose the smaller ones because they have, they can only be effective for uteruses smaller than 6 centimeters. Between 6 and 10, you can choose either a Marina or a copper IUD. More than 10 uterus size, no IUD is effective. So when you do a woman examination, if you know how to do a pelvic bimanual examination and measure your IUDs, you measure your uterus, you will figure out if this is an IUD candidate or not. Other things about the hormones is medication properties. All of them have some form of progesterone or estrogen. All of them have progesterone plus minus estrogen. The progesterone is needed because that's what prevents pregnancy in general, and that's what acts directly on the uterus. That is why in postmenopausal, if you remember in the menopause talk, أنا مش عايزة progesterone if I don't have uterus. Progesterone is one that stabilizes the endometrium. It acts directly, the field where the progesterone works actually, and the receptors manifest its therapeutic effect or physiologic effect is the uterus. No uterus, no need for progesterone. It like causes depression and swelling, and it's not really, it's not the happy hormone in the menstrual cycle. The doses in contraceptives are higher, much higher than the circulating one in the cycle, especially in the pills. علشان إيه؟ عشان the gastric bypass. عشان if the liver is there, most of it is going to be discarded. So you want to get a physiologic impact. فمثلا, the estrogens and the estrogen in the body is picograms, which is like 1 in a million of a microgram. But the dosages of ethinyl estradiol is in micrograms. So 6 times the normal levels of estrogen naturally circulating, just to deliver the appropriate therapeutic effect. ليه? Because a lot of the estrogen, progesterone, or steroidal hormones are eaten up by the adipose tissue. Okay? Physiology, basic science. Doses differ between pills and patches and depot shots because simply the delivery would secure and guard the levels or doses of these hormones that are being delivered. Androgenic features. I really don't like it when OBGYNs say that all birth control pills are the same. They're not. If the name of the medication is different, then their therapeutic effects and byproducts are different. For instance, drospirenone is wonderful for women who have extra hair or like they feel bloated or swollen during the period. So I would prescribe something with anti-mineralocorticoids or anti-androgenic. Women who have thick endometrium and they need a potent progesterone to stabilize it, I would love to use norethindrone. This might be a lot of information. I know that. I don't want you to memorize all of this now. And I don't expect you guys to memorize and know all of these things. This is an accumulative knowledge. What I did in the past 20 years is I read every day a chapter about women's health, about medications, an article, a book, just to kind of build the big picture of why certain women come to me complaining that their doctor would not change their birth control, even though they don't feel it's the same as the previous one. Generic is different than trade name. This is a reality. Hormonal profile is different than a different. Okay, there's a question. Yeah. So the hormones that I would look at or medications that I prescribe in the pill or an IUD or in a patch, you really need to know what they have inside of them. The doses is higher than the natural circulating one for a normal woman, and they are lower than what I would prescribe for a menopausal woman because there is none circulating in their body. And the indications are different. That's why an excellent clinician would always remember, why did I prescribe this medication in the first place? What primary problem I'm trying to prescribe this medication for? In this case is to prevent pregnancy. Secondary problems, when you would look, for instance, احنا لما بنعمل medical education على فكرة هنا في College of Medicine, I like that every case has a worksheet. In that worksheet, you have primary problem, secondary problem. In this case, the secondary problem could be menorrhagia, for instance. And then I bleed a lot. For that, I want a potent progesterone. Or metrorrhagia, meaning my period is not regular. In between the periods, even though I don't bleed a lot, but in between the periods there's spotting and it bothers me. This way I think I want to prescribe triphasic, which is almost dying. Yani the pharma worked really hard in creating something similar to the physiologic cycle, but because clinicians are not willing to expand their knowledge, you just throw whatever you know on your patient. Tamam? So then medication properties, I was smaller. What would you do as a pharmacology company? Can somebody like think? Let's say I'm delivering 20 micrograms of ethinyl estradiol instead of 30 micrograms. How would you compensate for the lower dose? What would you do with the pill packet? Come on, guys.
Sorry, can you repeat that? Because like, I think the connection wasn't so good.
Sorry about that. So the one عندي ethinyl estradiol is 20 micrograms instead of 30 micrograms in the pill packet. If I want to change, أنا عايزة more steady delivery of the ethinyl estradiol, I am worried that it might cause cardiovascular issues because I have that bias that estrogen is bad and it can cause strokes and it can really like thicken the blood. I prepared a packet that has 20 micrograms of ethinyl estradiol instead of 30 micrograms. In order for myself to make up for that difference in the dose, 10 micrograms, what do you think the manufacturer would offer in exchange of lowering the dose?
More pills?
More days. Excellent, Kareem. More days. So instead of me doing 21 days of 30 micrograms and then 1 week off, I'll do it for 24 days and 4 days off. When you guys look at the pill packets or the prescriptions decision of delivering the hormones, you guys are intellectual, you're smart. The pharma companies uses the physiology and the basic sciences to better serve a woman with minimum side effects. So there's a trial, there are clinical trials, there are different ways of delivering the hormone. So you as a physician, when you look at the pill packets or the patches and notice that, oh, usually it's 30 micrograms, then what is the difference here? Am I prescribing the right medication for my patient? Is her problem having heavy periods or side effects from the estrogen being high? Based upon which you can decide to prescribe something that the insurance would cover, would deliver steadier amount of estrogen, but not as much. Especially if your patient is skinny and lean. She doesn't have much fat to suck that estrogen out of the pill. So she would have a good bioavailability of that estrogen, right? So I can give her a lower dose, steadier though on longer period of time. So as clinicians, you should have that knowledge. That's what I want to teach you. As added prescriptions. I want you to understand how pharma works. Because at some point, inshallah, one of you guys will be consultant in a pharma company. Look at these prescription packets and formulas and decide, like, why are you guys doing this? Why are we not doing this? And share suggestions. You guys are clinical scientists. You can offer perspective. And hopefully you have the side of a woman all the time. Now, consideration, we talked about the uterine condition. Is it a nulliparous? Is it a multiparous? Is it retrospect? Is it retroflexed? Is it anti-flexed? Is it easy to pull it and put an IUD in for those who have ever witnessed an IUD insertion? Is it larger than 10? Does it have a lot of fibroids? Are the fibroids inside the uterus? Are they submucosal? Are they intramural? Like all of these things, the uterine condition would decide if we can do a pelvic delivery of the hormone or we have to choose something else. Liver and liver and liver and liver. This is probably an area that doesn't have any research that is satisfying for me. Very insufficient. Women who have a BMI more than 35, likelihood of them having fatty liver is extremely high, extremely high. We don't know how fatty liver impacts OCP absorption. So for these women, prescribing pills, so the clinical association is that a woman is more than 90 kilograms. She may not absorb oral pills, so you have to counsel her that if you want to take a pill, I just want you to know that it may not work very well. We think that the adipose tissue sucks most of it and do aromatization. So she has high estrogen levels. There's no stabilization of the progesterone doesn't have a huge negating power. So there isn't a stabilization of the progesterone. هقولها بالعربي تاني عشان دي مهمة. لو أنا عندي huge fat tissue، لو أنا عندي مخزون من الدهون في المريضة كتير، the aromatization اللي هو تحويل الفات tissue لاستروجين is high، يبقى هي already عندها circulating high estrogen والliver may not necessarily be cleaning that. فأنا when I prescribe oral pills, I don't know how to expect أو يعني what to expect from these pills to behave already in the presence of a high estrogen. Estrogen عالي. البروجسترون يبقى مش كفاية. Progesterone in all preparations, by the way, is much higher than the estrogen. So the estrogen is like 20 to 30 micrograms. The progesterone is 3 milligrams, 2 milligrams, 1 milligram. So it's like 3 times, 3 zeros more than the estrogen circulating estrogen. The reason أصلاً we have estrogen is to simulate the physiologic cycle. So all what you need is to stabilize the endometrial lining, prevent it from thickening, so no fertilization or implantation would happen. تمام? The BMI fat content is really a very important piece of your patient to decide on what kind of hormonal delivery or vehicle you want to deliver the hormonal contraception to. Endocrine profile. If she has hypothyroidism, hyperthyroidism, period are not regular because of that, or high prolactin, which is basically a cause of infertility. Do I want to fix that first and then give OCPs? So for instance, على فكرة أنا قلت الكلام ده المرة اللي فاتت في menopause, I think, lecture. I don't check prolactin or TSH for a woman on OCPs. So if a patient takes birth control by mouth or a patch, يعني estrogen and progesterone being delivered via another vehicle, don't check endocrine profile. It will not be accurate. Age, how old is the patient? If this patient is young or older, do I want to prescribe something that would simulate a cycle so she would improve like fertility options later on? Is she old and skinny and smoker and I'm worried about osteoporosis, so I cannot prescribe Depo shot? Because I hope that you guys know that by now. Depo shot technically can cause osteoporosis and weight gain and acne because it has like that androgenic impact. Cancer profile. Does she have cancer? Is she predisposed to cancer? Family history of cancer? BRCA, for instance, BR breast genes like Angelina Jolie. Cancer profile is very important, whether it's personal or family history. The contraindications really for birth control or family planning, they can be plenty, but because we have so many vehicles to deliver, you have always something to offer to your patient for contraception if she does not want to get pregnant. Parity and coagulation profile. How many kids did she have? How much the uterus has worked? Neurovascular profile. Neurovascular meaning strokes before, clotting risks, hypertension, heart disease, migraines with aura, all of that is a neurovascular profile. Social history, does she smoke? Smoking is the biggest. Anything that increases clotting profile, like cocaine use, heroin use, all of these that can cause vasoconstriction or impact the clotting profile should be taken into account. Current medications, I have a couple of tools for you guys. Always check micromedics to see if the current medications your patient is taking بتتعارض مع medication, birth control pill you are prescribing or birth control method that you are prescribing. See if there's actually a negative interaction or a warning from micromedics. There's no like a list that you can memorize. Barbiturates are known to reduce that effect. By the end of the day, your question should be, is my patient on pregnancy? And it's so عايزة تسأله. Is she taking any medication that would make contraception unsuccessful? Otherwise, you have betrayed the patient's trust. That's when you look at medication list or profile you have to think about. Hormonal delivery, I put some links because I want you guys to understand ethinyl estradiol is the most commonly used. All of these are synthetic. فاكرين في المينوبوز احنا قلنا المينوبوز we use natural hormones, but in the contraception, it has to be controlled with clinical trials. So we use synthetic hormones so we can measure it in the studies, because that is not a goal that I can compromise. If a patient cannot get pregnant, does not want to get pregnant, it is a huge failure to drop the ball and give them a natural hormone, not knowing how will that behave, bioavailability or pharmacology profile by any means. تمام. So أنا عندي estrogens ethinyl estradiol EE. It's used most in UK and Europe. Progesterones, because contraception is progesterone dependent, هتشوف إن progesterones used in the formulation for OCPs are plenty, because that's the main player for contraception. That's like the decision maker. That's the deal breaker. Remember, acetate in general, لو انتوا فاكرين organic chemistry, acetate is one that stabilizes norethindrone and makes it more potent. So I don't need as high of a dose if I add the acetate. Kind of protects it from the hepatic or gastrohepatic breakdown. Drospirenone, I like to prescribe it when patients really have bloating or swelling or hirsutism, as I said before. So I would recommend that you guys, once in a while, read about the difference between these progesterone and why would you use one more than the other. Cost, expense, availability, and androgenic features or mineralocorticoids features or less side effect or potency, all of these things in pharmacology, all of the things that you learn in foundational and basic sciences really matter in your clinical understanding of how to translate that into practice. Monophasic is a steady doses for both estrogen and progesterone. That's the most common used by physicians because it's convenient. It doesn't really cause issues. طبعا. Monophasic is used a lot also in the 91 days cycle. 91 days cycles, مثلا, بستخدمهم أنا for somebody who has hormonal migraines or like very heavy bleeding or athletes. They don't want a period خالص. They just don't want a period. And believe it or not, sometimes if, you know, like they would be used for adolescents who do not want to do depot shots, or they don't feel comfortable having anything inserted in their bodies, but their periods are heavy and they miss days of school. So I would use 91 days of the monophasic. The problem with monophasic in general is the intermenstrual bleeding, because they don't simulate the cycle. So sometimes you may not stabilize the endometrial lining very well, and it will shed and drop some spots. That's what happens with intermenstrual period. فاكرين احنا لما قلنا اللوب اللي هي there is sometimes when you put the body or the physiologic cycle under a condition that simulates pregnancy, أو ما فيش ovulation أصلا, you stop the ovulation, there's no egg produced. There's like a loop, there's a breakthrough bleeding that happens because the corpus luteum goes out, but it's empty. There's no egg. We don't know why that happens. Okay. Biphasic progesterone dose changes. And you are trying to simulate LH in a few days during the ovulation, meaning you're trying to give the woman a sense of ovulation. You know, you're glowing, you're ready to mate, but there's no egg. That's the benefit of the biphasic. For women who have like, you know, I would use it with people who have some sort of a personality disorder or body dysmorphic disorder. It's a science, okay? It's a science. You look at your woman, you look at your female patients and you think, how can I best serve you? Okay, so biphasic, I would use that if she wants to feel like a glow of ovulation. Triphasic for women اللي مثلا عايزة تروح الحج, she wants to go pilgrimage or umrah, she doesn't want any breakthrough bleeding or anything like that, I would put them on triphasic 3 months prior to Hajj, because triphasic mimics the cyclical physiology and prevents breakthrough bleeding. تمام؟ مش عارفة
Excuse
أنا.
me.
Yeah.
For women who do not want bleeding, there have been a lot of talk recently about continuous use, like just do not use the placebo pills in the package. Continuous use, no bleeding. They say it's not harmful.
Oh, very good question, Kareem. So we only do this for 3 months, okay? The only concern with not going beyond the 91 days is that we don't know. Remember, estrogen is like a very minute player. We don't know that this estrogen exposure for 91 days can cause instability of the endometrial lining. So, arbitrary conclusion with insufficient research studies says that a woman needs to cleanse inside every 90 days to prevent estrogen build up or concerns for unhealthy or malignant proliferative phase. So 91 days, even for PCOS patients, for instance, we like them to shed every 3 months, at least, just to prevent malignant proliferation from happening. But there is no clear contraindication of why a woman would not use a continuous pill for 12 months. The only thing also you have to understand that evidence did not study pills as a LARC, meaning long-active reversible contraception. They're not studied for that reason. So the exposure for the ethinyl estradiol or the estrogen component of the pill via mouth is not necessarily studied for long use. So it's insufficient evidence, but not a contraindication.
Okay, thank you.
Yeah. So maybe we can work on that study at some point. Not that I want somebody to take a pill every day. That is also can be inconvenient. Most of the time, this is very successful with women with no kids. Surgical, as I said, you can have a vasectomy. It's an outpatient one. It can also be reversed, actually. But vasectomy is a huge reason for medical legal liability. A patient has to sign a contract that they have to come back for semen analysis. And a lot of times men may not come back and they can still be producing sperms. So they have to come back within a week after doing the procedure to prove that there are no sperms coming out of their ejaculate. And if they don't, they can't sue a doctor for them getting pregnant or having conception. Women, tubal ligation is a racism issue, by the way. a lot of times, if African-American women did not have their uterus removed, a lot of times tubal ligation was recommended for them. So there's a lot, there has been a policy that you cannot do tubal ligation before having at least one child and a woman crossing 30 years of age. A policy had to come into place in order to protect women who are not informed or educated that this is probably like a permanent, irreversible way. If we do it for you, where we cannot really guarantee that we can reverse it or you can conceive later on. And remember that all of these ways, cauterized, tied and cut, banded, all of these can actually cause scarring, and you have to cut the scar tissue completely and tie it, which means a shorter fallopian tube that is not easily regenerated. So even if they were to reverse it, there's no guarantee. And I had actually a handful of patients who did reverse, and interestingly, all of them are African-American women. So be aware of your biases, please. Tubal ligation per policy in the United States is not recommended before one child born and 30 years of age. Extensive counseling has to be done. And there was like the Eshur. Eshur actually was like a very nice period of time, I think between 2010 and 2015. And then lots of cases for early menopause, failures, pelvic pain. So it's not really yet as common as we would like it to be, even though it's like an outpatient one. It can be reversed. You can just remove the Eshur or the area where the Eshur is, but it's not really as commonly as used as the regular tubal ligation. So extensive counseling for that is needed. Emergency contraception, that is also important to know. It's dependent on the point of the menstrual cycle. So if somebody comes in a few days after their period and they had an unprotected sex and they need something, that's when you easily look, okay, so if you are more than 5 days, more than your period, and I can actually maybe, there's a link that I will show you guys here, if you can see it. Oh man. مش عارفة يا دكتور مصطفى حضرتك شايف can you see this? Can you see the algorithm?
Yes, we can.
Okay, perfect. فالالجوريثم ده يبقى small card, put it in your bag if you want to counsel for emergency contraception. It really depends how many days is from the last menstrual period, based upon which I will decide if I will be able to give you either Plan B, which is a very high dose of levonorgestrel. I would have to admit that one time I actually tried it just for the sake of knowing what my patients go through, and I can tell you, it sucks. Nausea, I actually vomited because I've never had hormones that high in my body at that very young age, but that was my early in studying my steps, and I'm like, okay, what does that Plan B feels like? Not a good idea, don't do that. But it can give you nausea, it can give you bloating, all of the things that a woman would mention after taking those, take them for credit. Please show empathy, TLC, tender loving care, as much as you can, but you can do pill, patch, ring, injection, or implant. The only one that is not studies for emergency contraception is the Mirena IUD. Otherwise, you can use anything. Even like, let's say, for instance, I had one-time consultation. I'll go back to the, you guys will have the link, inshallah, so don't worry. Can you guys see the presentation back? Can we see the slides back? Thumbs up.
Yes.
Okay, perfect. So in this case, the whole idea is to give a high dose of progesterone. You're pregnant, you're pregnant, you're telling the body you're pregnant. Okay, you don't need to do implantation, don't fertilize that egg. So if there's a huge like a 1 week from the last menstrual period, you're actually talking, if the menstrual period was 5 days, that's day 12, you know? So for 72 hours, if we catch them, then we kill the sperm. We kind of stabilize the endometrium to think that we're pregnant. We don't want any egg to be released. We don't want fertilization to happen. It's a very high dose of progesterone in order to make that work. But the Mirena did not necessarily look at, we didn't really look at the Mirena as a way. So all of the other ones, you can use them. The claim scientifically, it's not an abortifacient, meaning none of these medications will abort a child if they were to be pregnant. And I can testify to that. I put implants into women who didn't report intercourse unprotected. They came back, I removed it because they were pregnant. I put an IUD in a woman. After a while, she didn't really do the pelvic rest. Apparently it wasn't properly placed. She came back pregnant. We just removed it safely. So they don't really abort a fertilized egg. And that takes me to the verse I like, right? Once the fertilized eggs is implanted, at least people who are faith inspired, we do know that there's nothing that can actually abort a baby that is meant to be born. We're not really that powerful as scientists. I think we sometimes have an overinflated ego, but they're not abortifacient. There's no study that shows that they can abort a child or an egg that is already implanted and fertilized. Switching. This is very important. We get that often, honestly. Like, I tried the pill, doctor, and I keep forgetting it, and I get menstrual bleeding, and I spot a lot. This will help you a lot, guys, understand. One common rule is that if you were to stick to switch any of these to an IUD, you have to insert the IUD within the 5 days of stopping any other hormones. So all of the other hormones, all the other IUDs will have 5 days protection in between. The other ones, you really need to pay attention that you would need to have some overlapping. So for instance, if you're switching to a patch, you need to put the patch 1 day before stopping the pill. And follow this. This is very much like the Reproductive Health Access Project. They've done this very easy access. You can print that slide if you want, or you can put it on your electronic library. But it's very easy to understand. So if you were to switch from a pill to a ring, no gap needed. You insert the ring the day after taking any pill in the pad. This is very important because a lot of times medical error switching, if you have a mean patient, they will sue you. And it's not really just about medical legal. It's really failing your patient. She does not want to get pregnant, and we have to respect that. I have heard so many physicians think like, what's the big deal? She got pregnant, it's not a bad thing. Well, it's not a bad thing for you, but this patient does not want to get pregnant. You have to respect a patient's wish. Aywa Kareem.
About these gaps, the days before stopping the pill, etc. And the days after stopping the pill, do I have to wait 5 days after stopping the pill, or is it okay? Like if I start, if I put in the IUD like the day next, is it okay?
Yes.
Do I have to wait with some methods like?
No. Actually, the research pretty much says that whenever you get the patient inside, I've never let them wait. I go actually into the stock. If there is an IUD, I put it in there. You want to stop the pill, I let them know. If you want to stop the pill, your period may start. Nobody knows how your body will behave. So sometimes, like some of them have dates. They don't want to bleed. So a lot of times when I put the IUD in, I let them know that if I was to put the IUD in, you have to have pelvic rest for 2 weeks. That's another factor, factor. So to prevent pregnancy, you can put the IUD anytime. And if you put the IUD, they can stop their pill at any point. But the IUD, in order for the switching to be safe and reliably preventing pregnancy, has to be put within 5 days from the last pill. If not, then they have to use an extra barrier, right? It's like you always have a plan B. And for you to know, you can put the IUD at any point, and they can stop the pill if they want to. I don't recommend it because I don't want them to bleed. If they want to stop the pill, they can stop it the moment you put the IUD in, not knowing how their bleeding will behave. But they also have to understand that if you place an IUD in, they need a pelvic rest. No tampons, no penis, no nothing pelvically, nothing for 2 weeks in order for that to be successful placement. And not only for the IUD, by the way, in general, you don't have to wait. For the IUD, you need pelvic rest for 2 weeks. Otherwise, you cannot guarantee the success of an IUD placement. People do all kinds of things in sexual intimacy or like an intimate interaction. Anything can happen. Pulling of the IUD can happen. Misplacement can happen. Sexual infections, right? HPV, herpes, all of that can happen. And we don't know, like when you have a PID or pelvic infection, currently now, luckily, we don't have to remove the IUD. That's the good news, because in the past, if there was a pelvic inflammatory disorder or infection, the previous recommendations were to remove the IUD, assuming that introducing the IUD in that sacred area has caused the infection, but it's not anymore the recommendation. Rephrase your question.
I can't connection settings.
One more. Okay, one last thing. Some patients do experience like some kind of menorrhagia after stopping a combined estrogen progesterone pill, and copper IUDs do have the risk for menorrhagia. So should I take this into account or like wait a little bit because of it?
Oh, that's a very good question. Are you saying that double exposure to hormones can actually cause abnormal uterine bleeding? Is that what you are thinking?
No, I'm talking about like, you know, after long-term usage of pills, if you stop it, you may experience like menorrhagia, breakthrough menorrhagia, like an increased amount of bleeding, right?
Yeah. So yes, some women actually do report that. We don't know if, so remember, we go back to the pharmacology, birth control pills, any hormonal, the huge part of what they do in preventing conception is by thinning the lining of the endometrium. That's why actually that's how we learned that we can prescribe these hormones for menorrhagia rather than preventing conception. That will be a secondary indication. Now, for them to have menorrhagia back after stopping the birth control pill, that's when you have to look up abnormal uterine bleeding. Abnormal uterine bleeding is expected at the poles of the reproductive spectrum. When you first get puberty or menarche, and then when you are about to drop your hormones and graduate to the milestone, which is menopause, right? If there is an abnormal uterine bleeding in between, I want you as a clinician to invest in why this is happening, right? I think what you may be asking is the birth control pill, we're actually making those steady since we use monophasic, right? If we use monophasic birth control pills, you have made it steady for so long, and now the physiologic cycle is coming back, thickening the endometrial lining, preparing for a baby, right? In this situation, you can treat the menorrhagia as the primary indication, not necessarily worried about contraception. You have to address it as a primary indication. And it's not caused by stopping the birth control pill per se. It is caused by multiple factors. The pills were controlling potentially the endometrial lining if they were monophasic and steady, but stopping them did not necessarily. The birth control pills will cause menorrhagia. So I don't necessarily include this as an absolute statement in counseling. I just tell the patient that I do not know how your uterus will behave after you stop the contraception. So make sure that you're stocked in your bathroom and that your bleeding may go back to either previous to what it was before the period, before the pills, or something different. And you have to talk them through why the menorrhagia happened in the first place. There are multiple, by the way, treatments that are non-hormonal that can stop bleeding.
Thank you.
You're welcome. Okay, the side effects. Why would I stop the oral birth control pills? Abdominal pain, chest pain, headaches, eye problems, vascular accidents, or increased blood pressure. I have seen women blood pressure increase only on OCPs. In that situation, I would actually write in their diagnoses, in their medical history, contraindicated, OCPs are contraindicated. Consistently at home and in the clinic, the OCPs is the only cause for hypertension. So in this case, the neurovascular profile does not allow me to provide them with anything that is estrogen containing. So remember the aches, these are complications of OCPs for which you can stop them. IUD complications are pregnancy. That's the worst complication that can happen. That means a failure of therapy. Abdominal pain, a lot of times it can be migration or endometritis or malpositioning. That should be looked into and maybe pulled, or sometimes perforation can cause abdominal pelvic pain. Infections, this is, as I said, is like a relative complication or contraindication that was to happen in the pelvis outside the uterus. You can keep the IUD, or if the patient does not want to remove it because she's adamant that she cannot take the pill and does not want to get pregnant, you can start an endometritis regimen, doxycycline and azithromycin for that patient. Not feeling well, I just don't want it. And by the way, you guys will be surprised. IUD progesterone-based ones, they can cause hair loss. I've seen it. And it's written in the pamphlet. For some reason, progesterone does like the pregnancy-like effect. So not feeling well, or I don't want it, I don't like it. They can come with so many options. I usually teach my patients that you can always tell me that you don't like it without having to, like create reasons. So sometimes they would say, my partner feels it, I feel like something coming out. It's, there's no way you can feel the strings or, for them to cause significant pelvic discomfort unless there's an associated infection or bleeding or scarring, like people who had LEEP before. If they're not feeling well with it, you just remove it. Strings missing, you don't see them, you really need to remove it before it migrates into the abdomen, and that's a surgery. All what we do with whatever in contraception is that you're trying to avoid hysterectomy, which was one of the things that people did to prevent pregnancy, sadly. Drug interaction tools, these are the things that I want you guys to use. These are links. I usually use the Micromedics the most. I have the drugs app and the Hippocrates on my phone, as a phone app on my iPhone. So you can use these and look at the medication that you are trying to prescribe, figure out which class it is, and if there's a contraindication between that medication, the class of the medicine, and the medications that the patient is on. And LASM consistently, I'm hoping that there will be research. So consistently renew and update your information. The moment that you think you know it all, you are a dangerous physician. So check these apps frequently as much as you can. Any questions before we go ahead in the case discussions? And I don't want to talk as much in the case discussions, please. Okay, Kareem. أنا ببسط لما بيكون كريم. I really like it when Kareem صراحة. Okay, so we have a 29 years old female. She is comes to your office, symptoms of upper respiratory infection. During the visit, she mentions she ran out of birth control pills 2 months ago and would like to restart them. This is really atypical. They're coming for something and then they want to discuss something else. The last time she had intercourse was 4 days ago, not 7, 4 days ago, and she did not use condoms. Her last menstrual period was 2 weeks ago, 14 days, more than 7 days. She's overdue for a pap test and declines one today. Vitals are normal. Physical exam is unremarkable, except for gunk in the upper respiratory infection symptoms. Urine pregnancy test is negative. What contraceptive methods that could safely be started today? Mark all that true. What is she asking for now?
She's asking for a restart of contraception.
But technically,
it's 4 days.
That is unprotected sex. So what is she asking for?
So is 4 days enough for the beta HCG to appear in the urine test? I don't remember this.
Well, the urine pregnancy test is negative. Are you asking me if HCG will be apparent within 4 days? Does anybody know?
Emergency contraception. Is it give emergency contraception?
Excellent. She's actually asking us for an emergency contraception. She can't tell you that. That's not, she cannot, she doesn't know. She just wants to make sure she doesn't get pregnant. That's what she's telling you. And maybe because she has, she hasn't, pregnancy added to my list. So she's asking for emergency contraception. You asked a good question. Is the urine pregnancy test reliable within 4 days of unprotected sex? Especially that her period, she's technically around the ovulation time. No, it's not. So what do you want to do?
A copper IUD.
Seems like the best to do. All
Go ahead,
right. So
Shamaka.
it seems like the best thing to do because it's still within the 7 days that a copper IUD would work. I mean, honestly, it's still within the 5 days that Ella would work. But it seems like she might want to do long-term, depending on the conversation. So if she wants long-term, copper IUD would be the best. But if she kind of wants something right now, then Ella pill would be the best.
Excellent. Okay, so we have the pill, which is basically the combined oral contraceptive pills. What else? Remember, we said, Hussam said a very key word. He said emergency contraception. And her period, her last unprotected intercourse is less than 7 days. Everything else is a distraction. Remember what we said about the emergency contraception less than 7 days?
Yeah, the copper IUD.
All of these are actually options except the Mirena.
Oh,
She has a respiratory infection, that's all. And everything else is normal. She used pills before. We don't know anything else. Informative model. I would tell her that all of the options are open for you. Whatever you want, we're here to serve. You want the pill, it's available. You want the patch, it's available. You want the ring, it works. You want the copper IUD, we have one in the stock in the back room. You want the depot shot, also works. All of these actually work.
but if everything actually works, why do we especially have these high dosage pills? Like we can just give a normal combined estrogen contraceptive pill.
Are you asking me if they all work, why don't you use the most convenient one?
No, like why do we there's doses like the plan B pills, the high dosage progestin pills? Why do we have these if we can just use a normal combined estrogen progesterone pill? Like why use the other one? Especially it would be more expensive even.
Yeah. So that's a very good question. The plan B is most successful within the 72 hours up to 5 days. Now, according to recommendations, that is just that was one option. Now, all of these are other options, by the way, for the women. That's the update, right? The plan B is, what's the good thing about the plan B? She doesn't need to come and see you. Plan B is over the shelf, right? She doesn't, and I told you, that's why I told you, that's why I shared my story of plan B. When I take it, oh my gosh, it's yucky. It's disgusting. Like the feeling, I would rather get pregnant than take a plan B. It's nausea for 5 days. I vomited 2 days back to back. My belly, I felt like everything was messed up. It's 150 milligrams of progesterone, for God's sake. The whole dose for 30 days is what? 30, it's like a 5 days of 5 days of combined pills. I took if I took 5 pills in 1 day, it's a disaster. It's not really a pleasant feeling. But in this case, she doesn't want actually just to have an emergency contraception for the moment. She does not want to think about that later on. That's the reason she knocked your door. Okay, I have a respiratory, I have the sinuses, and I want my doctor to prescribe me something so I don't have to worry about that later. But plan B, she can get it over the shelf. She doesn't need to see you for that. That's why plan B was made, to kind of overcome the healthcare access barrier. But all of these can be an emergency. That's a very good, I actually failed to prepare you guys mentally for that. The plan B, the best part of it is over the counter. California now and New York are fighting to make OCPs over the counter, but the problem is their profile for hypertension, for neurovascular issues, for cancers does not allow these to be safely over the shelf because of the estrogen component, not the progesterone. But you can put a plan B, 150 milligrams of progesterone, disastrous over the shelf.
Okay, what about the dosage of a combined estrogen progesterone pill? Is it just the regular dosage? The same
which
as
one?
if I was using
The-
it for contraception?
Sorry,
The
can you
normal
repeat the
COC
question?
pill. Okay.
Oh, okay.
In this patient,
Combined pills?
yes. What dosage would I use in this case? Like no special dosing?
I'm sorry, I'm not following. The question is that the combined oral contraceptive, what is wrong with it in this case?
I think he's asking.
No.
Go ahead, Shamaka.
So I think he's asking, so in this scenario, we're asking about emergency contraceptive. So for the first answer choice, the combined estrogen progesterone pill, he's asking, since plan B is 150 milligrams, what would be the milligrams for this combined estrogen progesterone pill that we will offer this patient?
Well, this is going to be estrogen and progesterone together, and the pills usually are between 20 to 30 micrograms for ethinyl estradiol and 3 milligrams of progesterone.
So I just don't have to give extra or something.
So the plan B is a very high dose, basically really to kind of shut down any potential for proliferative phase. It really prevents implantation. It works directly on the uterus, like you're stabilizing endometrial lining that it's not thickening at all. This is what progesterone does. Thinning the pill. That's why IUD with a Mirena IUD is the best for perimenopausal bleeding because gosh, it thins. If you were to do ultrasound studies, if you look at the clinical studies, it really thins the endometrial lining. You can, that's why with Depo shots, you may have no periods whatsoever with it. And sometimes with Mirena, women do not have periods at all, if they're lucky. But the pill, basically in this case, would provide this woman, since she is less than 7 days into unprotected intercourse, would provide her with the emergency contraception, not being abort efficient, as well as long term. So you can take that on a daily basis, no need to do anything extra. And I would tell her, like what I would tell any patient who's starting the pill, you still need to use barriers within the first cycle until you get the first menstruation on the first case, on the first month. And then the month after, you are good to use just the pills with no barriers. But with the IUD, I don't need to tell them that. Once the IUD is in, she's fully protected. She doesn't need a barrier. Just the 2 weeks pelvic rest. But with the pills, with the patches, with the ring, remember, with all of these hormonal ones that are like using, that are not pelvic, you have to use a barrier in the first cycle. You guys remember that, right? Yes, no? Okay, good job. So in this case, all of the above are okay except for the Mirena. Of course, you're going to counsel her for each one of them, but all of them are applicable to help with in 7 days. Okay. 24 years old African-American female, G1, P1, meaning got pregnant once, had 1 baby, no miscarriages, no preterms, presenting for contraception counseling. Last pregnancy, had C-section for a preemie, 34 weeks patient, had gestational diabetes and preeclampsia, currently not using any form of birth control. Last menstrual period was a month ago, lasts 5 days, occur once in a month, no dysmenorrhea, no pain with periods. Last unprotected intercourse was 2 weeks ago. She has hypertension with CHF. She's on Lasix and lisinopril. She does see a cardiologist periodically with no complications in her case. Her BMI is 57, so very morbid obesity. Blood pressure is normal. And last pap smear was normal last year. She plans on having gastric bypass within the next month, and she wants a depot for birth control. What do you want to examine or do with this patient? Do you want any labs before starting any birth control? And is depot a good choice for this patient? If not, then why, and what are her options?
I think we talked about the liver, since she is obese, there's a high risk of fatty liver disease maybe, so we may need to check her liver function test maybe. That's
Okay,
one
liver
thing.
function test. ALT, AST. What a very important lab that you need before starting birth control for all women?
Pregnancy test,
Pregnancy test.
Pregnancy test, okay.
of course, yeah.
Okay, she got a pregnancy test. It was negative. Remember, there was unprotected sex 2 weeks ago.
Okay, is it blood beta
She has hypertension. Let's read it up. Well, you can get a beta HCG if you don't like the urine one. You can get the beta HCG. This patient struggled a lot to find a physician that she can trust in the system. As young as she is, she got pregnant and she got help from her community in order to save that baby. She was so excited to be a mom, but she struggled a lot with minimal empathy from the system. And now she's trying to become healthier. So she wants to make sure she does not get pregnant for now. So meaning she does not want permanent sterilization. She just wants to take care of her health until she gets better so she maybe can have another child. So pregnancy tests were negative. She has hypertension with CHF. Blood pressure is normal, I told you that. Do you want to examine something else?
Any tendencies to for coagulation, for thrombosis?
Okay, excellent. So I would do, we said LFT just to kind of figure out if the liver is functioning, creating, that's the clotting coagulopathy factory. I assume you want to do factor V Leiden, protein SC. You just want to figure out her coagulopathy, but that would be preoperative preparation. That would not really, I don't know how would that serve your contraceptive choice.
I would not give an estrogen containing contraceptive.
Beautiful, love it. This is the map. I love this algorithm. So in this case, this patient is not a candidate for estrogen containing birth control. Check. So my list of my inclusion list is much smaller, right? So now I have the progesterone-based ones or chemical, right? So the question that, yeah.
Or like physical, like the IUD, copper IUD.
Copper IUD is an option. She's asking about the depot because her friend has done depot before. It's progesterone based. Do you think depot would work for this patient?
I don't see why not. Maybe I'm wrong.
The weight, I think depot shots cause weight gain, given her body mass index and weight.
Excellent. And unfortunately, she said that nobody ever told her or told her friend that Depo shot can cause weight gain. That's why she was asking about it, thinking that this is the best and only option that she has, because this is a community reference. So Depo shot in her case, for multiple reasons, would not work. We do not know how would the 150 milligrams of levonorgestrel behave with that much fat content, right? Especially that her estrogen with aromatization may not necessarily be controlled and not necessarily expected. So in this case, Depo or even an implant, especially if she was to get a gastric bypass and there's a concern for skin laxity, she may not be a candidate for an implant either. Which leaves us basically with pelvic options that I would recommend for that patient. So it's either an Mirena, which would help stabilizing her endometrial lining, or a copper IUD would pretty much not necessarily hormonal concerns. Now, unfortunately, luckily this patient actually ended up in my clinic because a lot of people would just not do the IUD because of her BMI. That's the bias towards weight. It was very easy and smooth operations because her pelvis was used only once for C-section. She's very young, she's 24. Her BMI is really constitutional. So even though like his BMI is 57, that sounds really big, but there's a bony structure in there. So it was very easy to place a Mirena IUD. That patient, she was very thankful.
So why wouldn't they go for an IUD? Like, is it a physician convenience thing?
Unfortunately, yes.
Okay.
I introduced bariatric beds into the clinic because you know, like you don't get to tell women, you don't tell men, like you get all of these bariatric beds for vasectomies, for skin procedures, for pumps, for you know, better erections or better ejaculations, but you don't think that a women's health clinic does actually benefit from bariatric beds because in the back of their mind, women should meet certain standards. So in order to get a bariatric bed to do an IUD, that needed like a lot of paperwork on my end. And they're not really hard to place an IUD in there for as long as the pelvis is not really aged or lax. So if you have a good pelvic muscle, you can easily visualize the cervix. That's all what you need in order to get an IUD in. So the biases really come between you and better serves an optimal service for patients. That was a great learning experience. I did not know myself that Depo was not a good option. I just had a feeling. When I looked at the studies, Depo is not really recommended with women BMI more than 27. You have to do extensive counseling. And it's better to give breaks after 2 years. OB-GYNs themselves actually did not know necessarily that this was researched or recommendation because it's not in the ACOG, right? It's not really part of the guidelines. A lot of the women's health issues are related to discoveries by clinicians and physicians inside research. We still don't have a common guidelines, which makes sense because culture plays a huge role in how you provide yourself. I'm not going to take much of your time, guys. We'll move to case 3. We have a 38 years old, history of 3 pregnancies, 2 deliveries, and 1 miscarriage. She comes to discuss contraception. She's divorced, but recently sexually active with a new partner. She has hypothyroidism. It's controlled on levothyroxine. She drinks 4 glasses of wine per week and smokes 1 pack of cigarettes per day. Vital signs otherwise are normal. What appropriate contraceptive options you can include for this patient in your counseling?
Given her age, she's more than 35, and her smoking status, combined with contraceptive pills would not be a good choice.
Exactly.
Excellent. Excellent. I am so proud of you, son. So anything that is estrogen containing, I don't know if I actually went through the contraindications. I think I may have went through the contraindications quickly. Yeah, so this classification system for conditions that may affect contraceptive choices, that you can actually download the app. In this case, this patient is in category 4 because of unacceptable health risk. She's 35 plus age-wise with smoking cigarettes. Even though, by the way, the recommendations are changing to empower women, I think it's very dangerous to put a woman who is a smoker or has any risk factors for cardiovascular incidents on estrogen-containing contraceptives. Believe it or not, I've seen it. It's not like I haven't. In Kentucky, I had a patient who's 80 years old, heavy smoker. Because you know, Kentucky state is like the tobacco land. That's what they do. People, like, that's what they farm, tobacco, right? So they don't have that much aversion yet against smoking. It's very common in the South that smoking is still like higher rates than what we would like for a developed country. She was on hormonal replacement therapy and smokes like crazy. But she's counseled, counseling is documented. And, you know, like that case sometimes is used, my so-and-so smokes and she's on that hormone. I would use informative model. Here are the risks. If you prefer that, I just want you to know that you are at higher risk of developing this, and that. If this is what you would like, that's totally fine, but I would like to tell you that this might be contraindicated in your case. Okay, but then informative model, in this case, you can use deliberative, meaning I am deliberately telling you that this is probably not the best or the healthiest choice for you. And at the end of the day, you're not their dictator, you're doctor. So in this case, what you're saying, Yahsam, that a combined pill, patch or ring are not an option, correct?
Yes.
Okay. Do you think that the vaginal ring can be acceptable option in this case?
Well, I don't think it's not acceptable, but my reading about it says it's not that effective.
Oh, the vaginal ring is pretty much like the patch. It just goes vaginally. It does deliver systematically. It's just not as, it's the bioavailability of ethinyl estradiol delivered via the ring to the systematic or parenteral bloodstream is not as high as it is for a patch or a pill. So it's still like a local activity. You know, you put the ring in there like every 24 hours and you change it for 3 weeks and then you give a week to have menstruation. But I would prioritize in this case a Marina, a copper IUD, a depot shot if she would be, you know, a depot shot for me is not necessarily recommended in this patient because I'm concerned with the smoking for osteoporosis. So a depot shot would be no more than 2 years and I would do extensive counseling. The IUDs would be tier 1, and then ring tier 2, and then depot shot tier 3. Just because of the smoking factor. And of course, I would counsel against smoking. The first 2 options are not applicable because they would be category 4. I got these cases actually from the board examination. So just you guys can figure out. If you do modules or what we call it, knowledge systematic assessment, these are the questions and then they put a narrative underneath those. I didn't even make it up. Some of the cases I have witnessed personally, but not all of them. I'm so glad that you are. I think Radhika has left after she is. Something I've always wondered is how the inflammatory response from the copper IUD does not increase risk for cancer. Wouldn't prolonged inflammation of the uterine cavity cause damage, increased risk of genetic mutation, or no? Because it's still inflammation. Very good question. Okay, so one of the attendees have actually asked, copper actually is a spermicide. يعني هو بيقتل السperms. It is a spermicide. It does kill the sperms. That is why it was used around the IUDs, which is like 3 millimeters. Hence, when I use a copper IUD, I want spermicide. I want a thinning of the uterine lining because it gives like a pseudo gestation stage. And if it is actually well placed, so you know, like the uterus, so 80 grams, حاجة صغيرة خالص. And when we talk about uterine cavity, you're talking about a very thin cavity as much as deflated balloon. عارفين البالونة لما انت بتمسك البالونة عايز تنفخ فيها؟ That cavity inside a deflated balloon, that's the cavity of the uterus. It's not bigger than that. So when I insert a uterine IUD, when I insert an IUD, I want the T-shaped side to go inside the fundus. That is the ideal placement. If we were to do an ultrasound for every IUD placed, I can bet money that the IUDs that are not placed in the fundus are more likely to cause menorrhagia as a side effect of placing the IUD. Because the implantation side in general for the uterine cavities are usually the sides of the uterus, not the fundus mainly. And that the implantation side, if I can control the fundus, then I'm sending a message to the whole endometrial lining that you don't need to proliferate. I have something implanted in here. It's genius, right? Now, does the chronic inflammation, first of all, it is a sterile inflammation. Why is it sterile? Because the structure of the uterus is, the uterine cavity is closed, the cervix is not open. And if you do the IUD placement the right way, meaning using the iodine, does anybody know is iodine is bactericidal or bacteriostatic? Do you know the difference? The iodine we use in surgical sterilization. Is it a bactericidal or a bacteriostatic? Does it kill them or paralyze them?
Is it bactericidal?
Excellent. And it only acts if I let the iodine dry. Yeah, we have to understand why science works in this way. Iodine dries up, and that's the only, that's when it kills. So when I actually put the iodine in there, I have to let it dry. When I put it around the cervix, I let it dry first round, and then I do a third round, very sterile, and I try not to repeat on the same areas from the same swab. Let it dry. That's how it kills. If you don't let it dry, it does not kill your bacteria. That is why there is a high instance of incidental actinomyces accompanying IUD insertion. And I have to admit that I have so many patients from Egypt coming in with an IUD, 60% of them has an actinomyces. They don't remember if the physician has used IUD on them or not. But when you apply the IUD to the cervix, please make sure to let it dry. And don't repeat the area, make it in a lollipop shape, okay? When you insert the IUD, that's the sterile field, everything is sterile. So even if you have an inflammation, not every inflammation is neoplastic. And remember that if I'm shedding, if I'm killing that lining, the likelihood of having one of these cells kind of transform into a neoplastic cell is very minimal. So that's how copper works. That's why the copper IUD still lives compared to the one that had nothing, which was meant just to cause an inflammation. So the copper has a spermicide, bactericide impact. It's a metal, it's a heavy metal. That's why it still lives. Take home messages. Contraception is an ancient concept. It's not really part of modern conspiracy theory. If you have that bias, please cleanse your mind out of it with minimum side effects and suits your patient's long-term goals. It has health benefits beyond family planning. Counseling should be informative, bare minimum, not parental, not paternalistic. Hormonal contraception is still a growing science. Any questions?
No, thank you, but you will be missed, so please come back.
If you care about your patients like that, I think, as I told you, I just want to know where you practice. You are a clinical scientist, and if foundational and basic science does not contribute to translational sciences and your clinical practice, that is really a problem. I do trust our medical education in at least creating the curiosity to understand why your patients are struggling. Well, trust me, if you believe the patient, you can get the right research questions. لما تيجي مريضة تقول لك أنا البتاعة دي اللي بتحكي عليها مش لطيفة. حاسس إن أنا I'm more nervous. When you give me these pills, I'm more nervous. I'm more anxious. Oh, my hair is falling. Oh, my eye is twitching. Believe your patients. I will negate Gregory House. Patients do not lie. They try to articulate their symptoms, and sometimes their articulation is not as accurate. Help them find the right word so you can find the right question, and both of you partner in finding the right answer. So contraception is not just to make you infertile, wala to kill babies in their mommy's bellies, wala to prevent the Arabs from growing, wala to kill like minorities. Contraception is a needed construct in our society, and we are so fortunate to have modern science compared to the very toxic modalities that were used in the ancient time. على فكرة الأكاجيا اللي أنا قلت لكم عنها في البداية that I told you before about, I left some links that are easy to read. These are very toxic, but women were willing to take it because the pregnancy was more eventful for them than the contraception. So luckily, we have better controlled clinical trials, more modern science, more tools, more technoscience. Just make sure that the patient interest is what you have on your mind is the patient interest first. Trust me. It's a huge difference, honestly, when we think within our own biases, within our sociocultural constructs, and then decide on behalf of our patients what's best for them. That is the oppressed mentality. When we are oppressed, we think of our patients as compressed. When we are empowered, we can educate and enable our patients eventually to make the right decisions once we both figure out what that is. But the evidence is growing, the science is growing, and I am so optimistic that you guys will contribute to that. I look forward to seeing some of you guys on the formularies for pharmas and clinicals and check the estrogen and progesterone doses to figure out what works best for a physiologic cycle for women. Make women happy, the world will be happy. Free one time today. I'll stop sharing and I'll send the PDF if you want now. Dr. Hussam, Shemeka, Dr. Mustafa, anybody has any questions?
شكرا يا
No, I
دكتور.
think that was, thank you very much.
You are so welcome. Now, Azim, if you guys can just wait for a second, I can actually send the PDF now. So Dr. Mustafa is extremely busy. I don't know how he does what he does, mashallah. But I will send you the PDF. And then if you want to share it with anyone, as I told you before, I don't believe in copyrights. I want everybody to learn the best. And if there's anything wrong that you guys find, I'll put my email here, inshallah, so you guys can email me. I thrive on feedback. I'm not concerned. I'm not trying to impress. I'm trying to learn with all of you. So thank you for the opportunity. And here's the chat.
I don't have any questions, but thank you so much. And I just wanted to give a comment. So anybody who's interested in anesthesia in relations to like contraception, Sagamadex, which is one of the drugs we use in anesthesia, you actually have to tell your patients that they should refrain from intercourse for 2 weeks because Sagamadex actually interferes with birth control, all forms. So yeah. So they have to refrain from any type of intercourse for like 2 weeks.
Can you put the name of the medication, Shemeka, please, in?
It would be great if you know the generic name because
Sagamadex. That's a great point. So even anesthesia, meaning for procedures?
Yes, so Sagamadex is one of the drugs that you use when you're waking the patient up. So it's like a drug like glycopyrrolate, which basically interferes with like succinylcholine. So it basically helps you wake the patient up. And if you use that form of, is a cholinesterase inhibitor. If you use that form, you will have to let them know that they can't have intercourse because they will get pregnant. Yeah.
So it reduces the effectiveness of OCPs if you are taking them orally, but if you have other things that are not orally, it should be fine, right? Just for the pills?
I believe so. Yes.
That is very helpful. That's my girl. Okay. Well, if you guys don't have any questions, I'll let you enjoy your weekend. Thank you so much for taking the time off your weekend to attend and share your questions.